Hello and welcome, fellow student doctors. Today, we will learn about ectopic pregnancies, which are pregnancies that form outside ectopic of the uterus. The key to understanding this topic for the boards and the wards is to remember that the T in ectopic stands for tubal, because 98% of ectopic pregnancies occur in the fallopian tube. Also, because the pregnancy forms in the tube, the syncytial trophoblast of the placenta cannot grow in size and number appropriately, so the beta-HCG levels are lower than expected for gestational age. Why would a pregnancy form in the tube? Because the tube likely experienced trauma in the form of pelvic inflammatory disease or other pathologies. You can diagnose ectopic pregnancies via a transvaginal ultrasound of the tube and treat ectopic pregnancies by removing the non-viable pregnancy from the tube via either methotrexate or surgery. By focusing on the T in ectopic for tubal, you can derive all the necessary information to understanding, diagnosing, and treating this life-threatening condition. We are in for an interesting discussion. Let's go ahead and get started. To prepare you for test day, you will be able to 1. Explain the pathophysiology of ectopic pregnancies. 2. Describe why the ampulla of the fallopian tube is the most common site of ectopic pregnancies. 3. Explain how to diagnose and treat ectopic pregnancies. And 4. Describe methotrexate's mechanism of action and side effects. As with all of medicine, to understand abnormal, you must first understand the normal. To do this, let's look at an image of a normal pregnancy where an egg is released from the ovary and enters the fallopian tube. The fallopian tube then has ciliated epithelium that act like a broom that sweep the egg along the fallopian tube as the arrows demonstrate. Now, let me ask you a question. Where does fertilization of that egg by a sperm usually occur? Here, in the ampulla of the fallopian tube. I'm going to say it again. Here, in the ampulla of the fallopian tube is where fertilization occurs. Ampulla of the fallopian tube. Super high yield, just make sure you know ampulla of the fallopian tube, and we're going to expand on that. So, that fertilized egg then travels along the course of the fallopian tube to implant into the uterus. How does that fertilized egg move along the fallopian tube? Again, the ciliated tubal epithelium pushes that fertilized egg along its course to the uterus, like a broom sweeping. Take a moment to appreciate how central the tube's function is to collect the egg once it's released from the ovary, then to being the site of fertilization, and then being the mechanism for sweeping that fertilized egg to the uterus where it can implant and grow. So logically, it makes sense that 98% of ectopic pregnancies occur in the fallopian tube. Sharing some percentages, the ampulla is the most common site in the fallopian tube for an ectopic pregnancy to occur. However, this should make perfect sense to you because the ampulla is also the most common site for fertilization of an egg by a sperm. And so you can see how these two events may be correlated with one another. And so, I want you to ask yourselves, why might this be? The reason is because the ampulla of the fallopian tube is the widest and longest section of the fallopian tube, so it takes the longest amount of time to move through it. Also, with the ampulla being the widest section of the fallopian tube, it can accommodate to a greater degree the implantation of an embryo in comparison to other parts of the fallopian tube. So friends, repeat after me. Ampulla, 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 because the ampulla of the fallopian tube is central to fertilization and the risk of ectopic pregnancies. And so, the next most common site of an ectopic pregnancy is actually the isthmus of the fallopian tube, which is incredibly dangerous because it is the narrowest section of the fallopian tube and cannot accommodate the growth of an embryo as long as the ampulla can. Both the ampulla and isthmus can and ultimately will rupture if an ectopic pregnancy is not properly diagnosed and treated. The ampulla, given its bigger size than the isthmus, presents a longer period of time where the pregnant person may be diagnosed and treated before rupture of the tube, compared to the shorter period of time from implantation to rupture that the isthmus may provide. Overall, ectopic pregnancies arise due to tubal pathologies. With the ampulla being the widest and longest section of the fallopian tube, it is the most common site for fertilization of the egg by a sperm and, as such, is the most common site for an ectopic pregnancy to form. As we reviewed on the last slide, the fallopian tube is a central highway that moves the egg and eventually fertilized egg to the uterus for proper implantation. Therefore, if any part of the fallopian tube is damaged, that highway becomes damaged and sets up roadblocks that can lead to abnormal implantation of the fertilized egg into the wall of the fallopian tube. I found this mental discovery interesting, so let me briefly share it. This diagram shows normal fertilization and implantation of the embryo. Do you see that each day the fertilized egg has significant changes in development so that by day 5-ish, the developing embryo is ready to implant into the wall of the uterus? Now, imagine that the fallopian tube is damaged and travel of the fertilized egg is delayed. Once day 5-ish comes and that developing embryo is ready for implantation, if it is still in the fallopian tube, now we got a problem because we have set ourselves up for an ectopic pregnancy to form in the fallopian tube. So if you think of the tube as a highway that must deliver the developing embryo in a certain amount of time to the uterus, tubal pathologies predisposing to ectopic pregnancies become intuitive. Let me show you by exploring 3 main categories of causes of tubal pathologies that predispose to ectopic pregnancies in the ampulla of the fallopian tube. First, past surgeries involving one or both fallopian tubes can leave scar tissue that disrupts the highway. This may include surgeries to prevent pregnancies, such as a tubal ligation, which makes sense because you are trying to permanently close the highway. So if that egg somehow becomes fertilized, it has no place else to travel and may implant into the fallopian tube. Moreover, prior ectopic pregnancies could have resulted in tubal damage, even tubal rupture, or necessitated surgeries to physically remove the ectopic pregnancy prior to rupture, a procedure called a salpingostomy. Next, the patient's reproductive history is important. Again, an ectopic pregnancy that is treated medically with methotrexate or spontaneously passes may cause scarring of the fallopian tube that disrupts the highway to the uterus. Infertility is also a predisposing factor for a couple reasons. A person who is infertile may undergo IVF, in vitro fertilization, which creates a probability game because IVF may lead to multiple embryos, up to 5 at a time, being introduced to attempt pregnancy, increasing the odds of both an intrauterine and ectopic pregnancy. And IUD, an intrauterine device, creates an environmental challenge to pregnancy such that the intrauterine pregnancies become less likely, purposely making the person infertile. Now think about it. If the IUD makes the uterus poor grounds for implantation, where does the embryo go if, and I mean if, the egg gets fertilized? That's right, it stays in the fallopian tube. Perhaps the most high-yield association is pelvic inflammatory disease. What 2 organisms are classic for causing pelvic inflammatory disease? Neisseria gonorrhea and chlamydia. The exam likely won't list their names, but will describe Neisseria gonorrhea as a gram-negative diplococcus and chlamydia as an intracellular organism. Lastly, a very high-yield genetic condition is Cartagener syndrome, also called primary ciliary dyskinesia, which is the perfect name. Bells should be ringing in your minds, friends, because the name tells you why this condition predisposes to ectopic pregnancies. The cilia are dyskinetic, or not moving properly. Without the cilia pushing the fertilized egg from the fallopian tube to the uterus normally, the risk of the embryo implanting into the fallopian tube increases. So, on the exam, look for a patient who has recurrent sinus and pulmonary infections because the cilia in the respiratory tract are not working and is having trouble conceiving, that is, infertility, because the dysfunctional cilia cannot move the egg properly along the fallopian tube. If that patient presents with abdominal pain, vaginal bleeding, and a positive pregnancy test, that person may have primary ciliary dyskinesia and is at a high risk for an ectopic pregnancy. Overall, any condition that results in tubal pathology predisposes for ectopic pregnancies. To diagnose an ectopic pregnancy, I want to emphasize a key point. In any reproductive age person capable of becoming pregnant who presents with abdominal pain, regardless of contraceptive use, what test must you order? A beta-HCG pregnancy test. Now, I want to ask you a few quick questions. What cells produce beta-HCG? Placental cells, specifically the syncytial trophoblast. Nice work. Next, why do you order a beta-HCG test and not an alpha-HCG test? This one is a little harder to answer and requires you to know that HCG is composed of two subunits, an alpha and beta subunit. The alpha subunit is shared by other signaling molecules such as FSH, LH, and TSH. Yes, HCG, FSH, LH, and TSH all share the same alpha subunit. So the beta subunit is unique to each signaling molecule. So, for HCG, we test for its distinguishing beta subunit, hence beta-HCG. Now, I'm going to blow your mind. How do we measure thyroid function? With a TSH level, right? What subunit of the TSH is measured? The beta subunit. So technically, we measure beta TSH, but we just call it TSH. Now that is cool, isn't it? Lastly, I want to note that a serum beta-HCG is more sensitive than a urine beta-HCG because a serum beta-HCG can detect a pregnancy within 1 week of conception, while a urine beta-HCG takes about 2 weeks. Okay, with that background, let's discuss diagnosis in a bit more detail. Diagnosing an ectopic pregnancy requires careful attention to the patient's presentation. The patient typically presents 4 to 6 weeks since their last menstrual period, putting them in their first trimester. Notably, if they are using a contraceptive, they may just report pain that may include breast tenderness and abdominal pain. Notably, the abdominal pain may mimic appendicitis. So it is extremely important to order a serum beta-HCG in any person capable of becoming pregnant who presents with abdominal pain to differentiate these conditions. Additionally, the patient's hemodynamic status is important, as they may report vaginal bleeding, which can be as minor as spotting. If the patient is hemodynamically stable, you can work them up with a serum beta-HCG and transvaginal ultrasound. If they are unstable, stabilize the patient and call for a surgical consultation. Let's imagine the patient is hemodynamically stable. The serum beta-HCG will come back positive, but the level of beta-HCG will be lower than expected for gestational age in an ectopic pregnancy. This is so high yield and it makes perfect sense. Looking at the diagram, which highlighted developing embryo at the same developmental age will have the bigger placenta after implantation. Simple, the embryo implanted in the uterus will have the bigger placenta, while the ectopic pregnancy implanted in the ampulla of the fallopian tube will have a smaller placenta. What cells produce beta-HCG? The syncytial trophoblast cells of the placenta produce beta-HCG, right? Since the ectopic pregnancy in the fallopian tube has a smaller placenta versus the embryo implanted in the uterus, it makes sense that the serum beta-HCG will be lower than expected for gestational age, doesn't it? Step 1 is a thinking exam. Try not to memorize anything. Use logic and critical thinking because that is what the exam will do to you. So, in a hemodynamically stable patient who missed their last menstrual period and reports breast tenderness, abdominal pain, vaginal bleeding, you need to order 2 key things: serum, not urine, serum, beta-HCG, and a transvaginal ultrasound. Not, and I repeat, not a transabdominal ultrasound, but a transvaginal ultrasound, as it has superior sensitivity for ectopic pregnancies. Classically, the transvaginal ultrasound will show an adnexal mass with absence of an intrauterine pregnancy. It may look like this. Now that you have diagnosed an ectopic pregnancy, let's talk treatment. The treatment of an ectopic pregnancy centers around removing the non-viable embryo. The methods for doing so depend on if the patient is hemodynamically stable. If the patient is not hemodynamically stable, meaning they are possibly tachycardic, hypotensive, and demonstrate other features of potential shock, then the patient is generally referred for surgery. Pictured here is an ectopic pregnancy, pointed out by the red arrow, that is located in what section of the fallopian tube? Step 1 loves to put questions that have an image like this with arrow and ask perhaps what section of the fallopian tube that is. So let's answer that, friends. What section is it? The ampulla of the fallopian tube, which is the most common site for an ectopic pregnancy. The patient may undergo a salpingotomy, where an opening is created in the fallopian tube to remove the non-viable embryo and then stitch closed. Conversely, if the tube were to rupture, depending on the extent of damage, the tube would likely need removal via a procedure called a salpingectomy. These are things you would learn for step 2. For step 1, the classic patient is hemodynamically stable. A good proxy is a normal blood pressure for board purposes. These patients will usually receive methotrexate with or without leucovorin to remove the non-viable embryo. This is where the points are for test A. So let's review methotrexate in more detail. As an overview, methotrexate inhibits folate, or vitamin B9 metabolism, which ultimately disrupts DNA synthesis. Fetal cells are rapidly dividing cells that have a high demand for DNA synthesis to meet their metabolic needs. So you will read that methotrexate is teratogenic because it blocks DNA synthesis, which leads to a halt in fetal DNA synthesis and ultimately termination of the developing embryo. For non-viable ectopic pregnancies, this side effect becomes its intended use. The boards will classically describe a patient with an ectopic pregnancy, something like a patient that has missed their last menstrual period and is now experiencing abdominal pain and vaginal bleeding with a positive beta-HCG serum test and a transvaginal ultrasound showing an adnexal mass. Then the test makers will ask, what is the mechanism of the drug that may be used for treatment? You know it's methotrexate, but step 1 wants more. They want the mechanism, so let's cover that now in the context of normal folate metabolism. Folate, vitamin B9, can be converted into dihydrofolate. Then, dihydrofolate is converted by dihydrofolate reductase into tetrahydrofolate. Tetrahydrofolate is converted into N5-N10 methylene tetrahydrofolate. And now we are ready for the big grand finale. Thymidylate synthase with N5-N10 methylene tetrahydrofolate serving as a cofactor and DUMP, deoxyuridine monophosphate, serving as a substrate, produces deoxythymidine monophosphate. Deoxythymidine monophosphate is a crucial pyrimidine for DNA synthesis. DNA synthesis is in high demand in developing fetuses, as fetal cells are rapidly dividing cells. And so, this biochemical pathway of folate metabolism demonstrates folate or vitamin B9's crucial role in thymine metabolism, DNA synthesis, and its importance in rapidly dividing cells of the fetus. Therefore, disruptions of folate metabolism by methotrexate can lead to termination of non-viable ectopic pregnancies, as the demand for rapidly dividing fetal cells for DNA cannot be met. Specifically, know that methotrexate acts here to inhibit dihydrofolate reductase. This is incredibly high yield. So remember that methotrexate inhibits dihydrofolate reductase to inhibit DNA synthesis. However, mommy got that shot as well, and you don't really think it's just going to affect the non-viable ectopic pregnancy, do you? So, side effects are important to know and should be intuitive, actually. Whatever cells in the body are dividing will be more affected by methotrexate, just like the rapidly dividing fetal cells. So, myelosuppression occurs as the bone marrow is rapidly dividing to produce red blood cells, white blood cells, and platelets. Skin cells are constantly dividing, making mucositis a possible side effect. Liver, kidney, and lung cells can divide, so hepatotoxicity, nephrotoxicity, and pulmonary toxicity are possible. Quickly, what are the stem cells of the lung? The type 2 pneumocytes. Nice work. And, as you can see, methotrexate is teratogenic as we discussed. Notably, I want to mention that the myelosuppression caused by methotrexate can be reversed via leucovorin, which bypasses the inhibited dihydrofolate reductase to produce tetrahydrofolate. And yes, methotrexate can still be effective even with a leucovorin workaround. It's all based on relative concentrations and the types of cells in need of increased DNA synthesis. Overall, make sure you know that methotrexate works via inhibition of dihydrofolate reductase. That will get you a point on test day. I almost guarantee it, friends. Alrighty, friends, it's time for a flash quiz. The question reads that a 26-year-old female presents with chest pain after painting her fence outside of her home. After workup for a myocardial infarction, an X-ray is taken, shown here, and a diagnosis of costochondritis is made. Upon further questioning, the patient has a history of recurrent sinus and lung infections. Why might this patient be at an increased risk of an ectopic pregnancy? A. Defect in acrosome. B. Defect in dynein. C. Defect in flagella. Or D. Defect in nexin. The correct answer is B. A defect in dynein. This patient has what autosomal recessive disease? Primary ciliary dyskinesia or Cartagener syndrome. The chest X-ray shows dextrocardia with the heart being positioned in the right chest cavity. This occurs because of a defect in cilia, specifically in the dynein protein, which inhibits normal ciliary functioning. Normally, cilia guide embryonic structures to their proper locations in the body, and so, with improperly functioning cilia due to the dynein being abnormal, this proper positioning of organs within the body does not occur, so the heart, which should be on the left side of the body, develops in the opposite side of the body, that is, the right side of the body. Moreover, without properly functioning cilia, the patient is at an increased risk of sinus and pulmonary infections because mucus that traps the pathogens cannot be cleared as effectively, leading to recurrent infections. Moreover, without properly functioning cilia, the female patient is at an increased risk of an ectopic pregnancy, as the cilia cannot move the fertilized egg that gets fertilized in what section of the fallopian tube? The ampulla, nice, down towards the uterus for proper implantation. This is such a classic Step 1 question, I just had to write it for you. For me, get this one right on test day. You can do this, student doctor. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Know that 98% of ectopic pregnancies occur in the fallopian tube. Where? In the ampulla of the fallopian tube, where fertilization occurs. Did I mention the ampulla? Any pathology affecting the fallopian tubes increases the risk of an ectopic pregnancy and include conditions such as surgery, prior ectopic pregnancies, in vitro fertilization, an intrauterine device, pelvic inflammatory disease, and primary ciliary dyskinesia. When diagnosing ectopic pregnancies, the most important tests include a serum beta-HCG, which is lower than expected for gestational age, and a transvaginal ultrasound in a hemodynamically stable patient presenting with abdominal pain, missed menstrual period, and vaginal bleeding. Treatment for a hemodynamically stable patient usually involves methotrexate with or without leucovorin, while unstable patients require immediate stabilization and surgical consultation. You must know that methotrexate inhibits dihydrofolate reductase, which disrupts folate, vitamin B9 metabolism, and DNA synthesis. Lastly, know that defects in the ciliary protein dynein causes primary ciliary dyskinesia or Cartagena syndrome, which presents with recurrent sinopulmonary infections, dextrocardia, infertility, and predisposes a person for ectopic pregnancy as the cilia inside the fallopian tubes are dysfunctional and cannot sweep that fertilized egg into the uterus for proper implantation. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there is a great big beautiful tomorrow.